And recently there was a court case out of Australia that I put into the EMDR News site on various things, and birth trauma was one of the things that we have information on. All right, everybody, welcome back. This is Dr. Tim Vermillion, and we are here with EMDR News. And as we do every weekday, we're trying to bring you EMDR News live stream. We are going to be talking about things having to do with mental health therapy in general, EMDR specifically. And on Fridays, we're going to be doing Red Fridays. So whenever I have a scheduled um, whenever I'm here on a Friday, we're going to be doing some type of veteran or military work right together. So we're going to have those discussions on Red Fridays. For those that don't know, Red stands for, and it's an acronym, and it stands for Remember Everyone Deployed, right? So we're thinking about all the folk out there, the soldiers, sailors, Marines, airmen, I don't know what the space ghosts over there. All of these soldiers that are away from their families, away from the lives that they know, and doing what they need to do in order to protect us here. So we're going to be having Red Fridays. Not this Friday, but next Friday we should have a guest speaker, and it is somebody that works with veterans that are having difficulty with homelessness. And so we'll talk about homelessness in general, but also the idea of homelessness and how it could affect people's mental health and their ability to participate in mental health treatment and get the best they can get out of it. Okay, so that's going to be on August 7th. So I'm going to be rolling out next Wednesday, this Wednesday coming up, the schedule for the following week. I already have it already done. Just, it's just when we're going to put it out there for you. So you're going to be able to see what we're talking about today. If you were able to look at the material that we had posted on social, is going to be on psychosis, on EMDR and psychosis. So we're going to get into that today. Uh, the way these things are going to be structured going forward, hopefully, is we'll be talking about just stuff first, right? The field notes, what's going on in the field of mental health, of EMDR, some politics stuff, maybe, public health, that type of thing. All having to do with the subjects herein, right? All having to do with the subjects that we are interested in on this site, which have to do with mental health and trauma-related work, and then trauma-informed therapy. So we'll be doing that work together, and that's the news kind of aspect of things. And we'll be getting that out to you as soon as possible in the front end of the material here. And then what we'll do is we're going to roll into the subject of the day, the soup du jour, so to speak. And today, again, that would be working on or exploring psychosis a little bit. Most of the stuff should end up, if not already in there, on the same day. Should be on the same day popping up as an article that kind of pulls in the research and things that we talk about here. Also, some of the items that we have here are going to end up being clipped, and you'll be find them in the practice desk. So it's almost like mini consultations when you go in there and you look at them. So right now, what should be coming to soon is having uh, the clips that have already been out there on social. we're going to be putting them into the practice area because they're really kind of definitive in terms of what they're talking about, whether it's cognitive interweaves or maybe even research. We hadn't even talked about research a little bit, but we're going to be having those little clips in there. And then you always have the opportunity to go and watch the entire presentation on Facebook, but it should live on YouTube for a little bit longer. And then also the live desk within EMDRnews.com will have the history of this as well. Actually pulling the embeds, the actual recorded stuff from YouTube. So that's what it'll be. This is supposed to be everywhere at this point. So if you're watching it, I usually tell people go to Facebook, right, or go to LinkedIn. But right now it's on Facebook, it's on LinkedIn, it's on YouTube, it's on X, and it's on Instagram. Now, where is it on these things? This might be a little bit different, right? Because right now, for instance, Facebook has both the Dr. Vermillion, right? That Facebook that I have, and also the EMDR News. So EMDR News is what I'm pushing, but that's where it is playing on Facebook in those two areas. And in LinkedIn, it's just on the Dr. Vermillion page. YouTube, it's on EMDR News, and then X, it's on the Dr. Vermillion page. Instagram is also on EMDR News, so it's kind of back and forth a little bit. So hopefully you can find me where you're looking for me. Some of the clips end up showing up on TikTok as well. So, check out TikTok. Maybe I've never been on a TikTok person, so it's new for me to do something like that. But here I am, right, trying to figure out how to monopolize my the social stuff out there, the social platforms where we can have these conversations. Again, if you have specific questions or interests that you want to know about, let me know, right? Because again, I do have my schedule for next week already planned, but you don't know it. So I can actually go in there and adjust that schedule based on what you bring to me. So remember to ask your questions. Looks like I got somebody on board. Okay, so somebody just reached out to me, so they're interested in coming on. And again, I have one person for next Friday that's going to be talking about veterans and homelessness. Not next Friday, the Friday after that. This Friday, no, we're still good to go. So sometimes Fridays, I might end up having to put like a pre-recorded up here, which is unfortunate, because I'm actually doing something, whether that's military or doing some trainings. Fridays tend to be when I end up doing things like that. So we'll see how it works out as we move forward. But this week we're good. Next week we're good as well. So we'll see each other on Red Fridays. All right. So I don't know if you've noticed, but if you go on to Instagram and you're a member of Emdria or like follow them, they're pumping out material now, right? They're pumping out what's happening over there in terms of who's going to be speaking and what workshops you're getting. I'm going to end up following up with some of that as well as we move forward, kind of get everybody interested, hopefully, that isn't already registered. But hey, it's coming up. It's next month. It's just a couple weeks away. It's going to be in Anaheim, California. It's going to be a good time. It's been a good time in the past. The summits, the conferences are always great. You get to see some of the people that you watch pop up in the EMDR world, big names and stuff like that. You're going to be able to talk to them. They're going to be right there. You're also be able to learn from them, right? The keynote speakers, and even just walking in the halls, you're going to run into people that through what you read, the authors that you read. Dr. Solomon, everybody's going to end up being there. I can't be sure that Dr. Solomon's going to be there, but that's what usually happens is you're going to find a lot of people there. So, big names, people that you're interested in meeting in the EMDR world, they'll be there. They do provide continuing education credits. So this is a good way to plus up on your continuing education. Also, the approved consultant and the trainer day are also included in this or a part of this, where you can get some of the education that goes along towards that. And what that also helps you do is move forward in your really reapplying, right? So if you're coming up on the end of a period of time where you need to redo your qualifications, that stuff is going to help you answer some of those questions when you get to that survey and stuff. So good stuff. Get out there, get to Anaheim, California, and take part. ISDSS again is going to be in September. I'll be there. Uh, I'm going with the NCPTSD group, the National Center for PTSD consultation people. So I'll be going there with them. I'm not speaking or anything like that. However, we're going to see what the public is saying, right? We're going to uh, understand kind of what the word on the street for trauma is. So that's one of the things that I'm going to do there anyway. Um, and then that's September. October is EMDR Humanitarian Assistance Program. These two things anyway. Those two are the Humanitarian Assistance Program and the EMDR are things that I volunteer for. They're nonprofit, and I'm willing to plug them anytime I can because of the important work that they do. Okay, so let's move forward on that. All right. Okay, so yeah, those are the three things that are coming up that are pretty big in terms of conferences. We have the July 27th piece that I've mentioned a couple times already, where not yeah, July 31st anyway. The end of your summit ability to get in there and get the credits and stuff, that'll be August 31st. If you haven't done the early bird thing, I think that's either ended or ending for EMDRIA as well. So, pricing, early bird pricing, you want to get in there if you haven't, check it out, see if you're still eligible. Um, the 27th, I think that's when Paul Marucci's conference is, I'm not sure. Just remembering things right now. Okay, so just keep track and keep an eye out. Go to EMDR News and go to Field Signals. It's on the first page. That you should see some of the more updated stuff, and you'll see what's happening in the world. Okay, so let's move on to psychosis, right? So when I talk to people about EMDR, when I'm doing trainings, when I'm doing consultations, it comes up. It's one of the main subjects that come up, like personality disorder, psychosis, bipolar disorder. These things that come up, or personality disorder, and especially borderline, right? These things are come up a lot, and people always want to ask whether EMDR works for this situation or this population. And when I say yes, what does yes mean, right? So EMDR works for a lot of these populations in different ways, right? Because I can't necessarily cure the schizophrenia that you might have. I can't cure the psychosis that you might be suffering from, per se. A lot of this is organic. Okay, this is brain stuff, like stuff. The best treatment right now is medication. Doesn't mean that EMDR doesn't do anything or doesn't help. And we have three papers that well, one's a feasibility study, but three papers that we were including today uh, in the research area and kind of going over, putting an article out about that, that combined to talk about psychosis and whether EMDR and trauma-informed work can help with psychotic symptoms. But here we have an interesting situation where we have the yes, right? They can actually help with psychotic symptoms. However, really what it's not for is more of the trauma-related symptoms. And in these studies, you do find that people with psychosis, those related symptoms, they do have an improvement in their PTSD scores. So we can help people that have psychosis with their PTSD, with their trauma. There's a threefold increase in the rate of possible sequelae psychotic experiences after having after being traumatized as a child. That's like 33% more of a chance that you're going to be suffering from some type of psychosis when you have had trauma as a child. Doesn't mean, it doesn't equal one thing, doesn't equal the other, but it does seem to have an effect in that way, right? Where many people, 3 times more people that had childhood trauma could end up having some type of surgence of psychosis. They've also found that if you get this early, that it has a better effect, right? So if you start working with people that are not yet in the throes of their psychotic or schizophrenic symptoms, but are at high risk, using EMDR and some other trauma-focused therapies can actually reduce the chance of having a pretty serious break, psychotic break, or episode of psychosis. And that goes across the board with age. So if you get people in their adolescence and when they're younger, there is some evidence that working with them, with their trauma, with EMDR has a better effect than if you're working with an elderly group or an elderly population. One of the ideas is because their mind might be a little more plastic. They might have plastic meaning changeable, right? Neuroplasticity, right? And more flexible. Their mind might still be a little more flexible than when they're in their elder years. But also, they find that there might not be as many traumatic incidents, right? Because you're not as old. You haven't lived the life that can continue increasing the amount of traumatic material over time. And that's what happens, right? It's not just the illness itself and the possible traumatic material that leads to it. But now, once you're in the throes of having a mental health illness, any mental health illness really, but talking about some specific ones that can lead to some pretty crazy social issues, isolation, maybe hospitalization, these things are traumatic in and of themselves. So what can EMDR help in terms of psychosis? And the research has you know, uh, pluses and minuses. So one of the pluses is that, yes, hey, it does help with PTSD. That seems to be across the board. Whenever they do the work, the PTSD symptoms come down, and that's on the CAPS, or the traumatic event experience scale, those types of scales. The reduction of symptoms does show up. Not necessarily in depression, right? So depression isn't as affected by this work, and that might just because of the work that they're doing, right? The specific memories and memory networks they're targeting. The other piece is that the psychotic symptoms also have an impact. So the biggest impact in one study, and this is a meta-analysis, was delusions. So they found that there was a good amount of change and a reduction in delusions. And they had some ideas about why that might be. Because some of the delusions might be tied up in the traumatic ideas and traumatic material. But they also found hallucinations, and this is in most of the studies they found. The hallucinations aren't affected by doing trauma work. So generally across the board, if they have hallucinations, they might not be helped by the work that we're doing. Okay, so we know the delusions might be helped. Also, paranoid thoughts might be helped by doing some of this work. And then those are the positive symptoms of psychosis, schizophrenia, et cetera. And then you have the negative symptoms. And one study, or one meta-analysis, did find that negative symptoms can be improved. The other study wasn't as sure. It could have been, but the way they did this study, the methodology, didn't really allow for them to see on the low end in terms of if it was helping even a little bit. It didn't allow them to see that change. So there might have been change there, but they couldn't really see it. So we know that, yes, you can do EMDR with the psychosis. Yes, it helps with PTSD. It can help with, if they're at risk of psychosis or schizophrenia, it could help reduce the risk. We know that it helps younger populations, adolescents and young adults, it has more of an effect on the younger population it does on the elderly population, but it still has an effect on the elderly population, just not as much. Hallucinations, not as much work there, and that's partially, they say, because it's a perceptual issue. It's not a meaning making issue. It's not a belief issue. It's not that type of thing. It's actually, a perception issue, which is not something that the therapy really kind of gets into. So that's interesting, I think, anyway, the hallucination piece. Let's see here. What else do I got? Oh, sorry. Somebody popped up on my screen. Um, so the other problem is PTSD symptoms, they last, right? I mean, the change in PTSD symptoms, the relief, the amelioration, the relief from the PTSD symptoms, that shows that even after 6 months or so, that sticks mostly, right? That's not the case for all of the psychotic symptoms. It's like a wave, right? When you are done the treatment, that is when the most effect is seen within those delusions, negative symptoms, and the paranoid thoughts. However, at 6 months, that change seems to kind of regress a little bit, right? So what does that mean, right? So in terms of long lasting stuff, it's not gonna, right now anyway, right? So far, most of the trauma effective uh, interventions that we have are not going to be helping long term in terms of some of the positive or negative symptoms of psychosis. So I don't know if that means that they would need a plus up or something along those lines, but in the end, we know that it does work. It just doesn't have a lasting effect on those symptoms. Again, the PTSD piece is huge though, right? Because it still means that we can do a lot of good work with our clients that have psychosis. If they're coming because they have trauma, we can treat them and have success in working with their trauma. So the worry in the past has been, hey, they're psychotic or they have psychosis. Can we do therapy with them in general? And people will be like, okay, the psychosis is a feature that is not going to allow us to move forward, right? It's not within the readiness criteria, or it's a contraindication, big words that we throw up there, to getting psychotherapy or having that appropriate therapy that works for them. So here we have some evidence that that's not necessarily true, that, hey, people can benefit from this. And that doesn't mean that we're just going to jump in and say, hey, send me all of your patients with psychosis or schizophrenia. But what it does mean is say, hey, making sure that they do meet readiness criteria, right? Again, that's still a thing. You still got to do that. They make sure they meet readiness criteria. And if they meet readiness criteria, if you can work on safety, if you can work on all those, ground floor things that we do in phase 1 and 2, and this person can sit there and benefit from actually doing the trauma therapy, that trauma therapy can be a benefit to them in the end. So there's Paul Miller has a book out there on doing EMDR with schizophrenia and psychosis. There's other books out there as well. So people are talking about this. This is a conversation, and the research is out there. The problem with research is that it's not all out there. And the reason is because psychosis is a contraindication. So if you're going to study EMDR, one of the things that they're going to say is, we don't want any psychosis patients, right? So all of a sudden, we don't have a full picture, and we have lots and lots of studies on EMDR and working with different populations, especially PTSD, but usually we are going to cross that line on psychosis. When you look at the studies that the meta-analysis does, and this goes back to learning how to do research or read research, what is generalizable about it? So it goes in, these meta-analysis, they're pretty good at telling you, hey, some of this stuff is, has a lot of bias in it. Some of this stuff might not be telling us exactly what we need to know, right? Because of how people were selected in a given study, or how big the study was, or who's paying for the study, right? Some of the bias stuff comes in on that level too. So, when you read this stuff, you also want to look at those that discussion and talking about what the limits are to the study. They're pretty open, especially meta-analyses, because they want you to know that like these 40 studies that we have, they're all interesting. Right, 10% of them we can put our thumbs up and be like, those are probably really telling you what the story is. The other 90%, they're giving context. However, right, and good context. However, they're less likely to be giving two thumbs up and telling you exactly what's happening. There's a lot of variables out there that people have to control for, and like it doesn't happen all that well. And then um, we'll probably get into more when we talk about depression and depren. This things come up in the next couple days or next week, but retractions, right? So there is a chance where you're doing a meta-analysis, you have 40 things that say, hey, this is good, right? And then later on, one of those studies is found to have methodological failings, right? Like it's not a good study. And all of a sudden, what happens to the whole meta-analysis, right? How important was that one study to the whole thing and bringing in a whole picture? So now, again, I push up this research stuff a lot, but here we go. And interestingly enough, I talked about anecdotal evidence and kind of the inductive reasoning that gets to like the path to RCTs, basically, how we get into more and more generalizable work. And when we get to these meta-analyses, when we get to these studies, and they're really trying to find look for these bias issues, limitations, etc. When you're doing anecdotal stuff, there's not as much of that, right? I mean, obviously you're biased, it's your work, right? So that's why at the ground floor, when you're doing your work, it's hard to take that as a generalizable thing and be like, hey, everybody should do this. However, maybe there's some stuff out there that if you can figure it out, and it's obvious, then so be it. Put it out there. You might have the golden ticket. What thoughts pop into my head is not a mental health thought, but if people were jumping out of a plane and somebody says, hey, I don't know why you'd be jumping out of a plane, but hey, here's a parachute. You might tend to everybody might tend to start using that parachute instead of using the plastic bag that they had, or um, their tablecloth or something like that, right? So that's a story of one that is able to permeate and say, okay, and the story of one can have an effect on everything, right? But generally, the story of one is just the story of one. Okay. All right. So that's where we are in terms of psychosis. Hopefully that was helpful. The short answer is yes, do it with psychosis. Yes, it can be really helpful. It can have some positive effects on uh, the negative symptoms and paranoid thoughts and the delusions. However, hallucinations are no-go across the board and don't generally have a good effect on those. And then how long the relief lasts from those symptoms is not necessarily very long. So that's an issue that you've got to keep in mind. And again, I don't know what that means. I don't know if there's like a plus up that people would want to do in order to kind of keep that process going, or specifically how those symptoms come back. So it's worth exploring, and people are exploring. There is a feasibility study that we had included in the work today that is looking at trying to do an RCT and how that all works. And I'm going to put the link to it here so that you can kind of see how people are looking at studying psychosis and EMDR. And it's not all just EMDR that's out there. They have trauma-informed PTSD work, that they're doing prolonged exposure, cognitive behavioral therapy, all of that stuff is included in these studies in some level as well. But I'm really just focusing on the EMDR. But again, psychosis can be affected by these trauma-focused interventions. Okay, so I'm going to go ahead and look at questions and what's been going on. Yeah, the main question was, can I do EMDR with psychosis? And the answer is yes. And this is kind of what we're talking about here. Another question is oh, okay. Is the talking about what grounding they need to do, right? So just think about your um, readiness criteria, right? Because we need to not only meet readiness criteria, but keep people in readiness criteria. So if they're in this place where they are slipping into some psychotic episode and they can't stay in the room, so you're not getting into the work done, then hey, we're not going to be able to do this right now. We need to do some more work on grounding and making sure that they can stay in the room with us. So that's a lot of the work that's going to have to be done there. Let's see, any other questions up here? Some of these questions I'm hoping were already answered during our talk today. So I'm just seeing anything that might need to be elaborated on. A lot of good questions though. Okay, no, looks like we're good to go. And again, feel free and reach out for any additional pieces out there. And again, this is going to be available on the YouTube, actually, wherever you see it right now. It'll probably be hanging out there for a little while as well. I think Facebook's got like a 60-day thing, something like that. But you'll be able to see it, and then it'll be linked to EMDR News. And then hopefully, if there's some good pieces in here, you'll find those in the practice area as well. Okay, so I think that's it for today. Yep. Let me just kind of show you real quick, for those that haven't been over there, what the website actually looks like. All right. All right. So here's the website. Make it a little big for you, bigger, I guess, for you. All right. So here's the website, and this is the main page here. Okay, and we have a bunch of links up there. That'll go to the different areas. You have research, practice, and again, research is where I'm going to put articles out and then have a discussion about the articles. So if you go there now, there's already stuff there. Um, and let me see. Okay, so it's here already. All right. So you can go down here and see what the Research Watch says, right? So we have PTSD with CBT or EMDR with CBT and EMDR and CBT for first responders, right? There was something about that. We have the feasibility study for testing DBT before doing EMDR and how those things were kind of associated with each other. And then we have all the other ones here as well. PTSD treatment during substance abuse, suicidal thoughts, right? So national survey finding more veterans reporting suicidal thoughts. And I think that went from like 9 to 13%. But it's like a decade. It's a pretty long review, but it's within the last 2 weeks in that review. And they find that they're um, having suicide ideation at a higher rate. On the plus side, though, they're also getting care, and they find that if you are within the VA, you're more likely to get care for your suicide ideation than if you're out in the community. Okay, so that's the research. So we take what's out in the research, and then we kind of talk about them a little bit in there. The practice briefs, again, we're going to kind of redo that. So right now it has some stories in there, but we're going to redo that very shortly. The research watch is about what's happening, and you'll find on the home page that there's a big section of kind of like what's really happening in the moment. Okay, so even this one was EMDR, Australian courts and witness memory, a legal question. There's actually a new paper out there, or a paper out there that I'm going to be pulling from. I think it was just done in June 2024 that talks more about the subject of judicial involved people and the effect EMDR has on memories. So I'm going to be working on that one and bringing that one to you as well. Okay, so that's that. And then we got analyses. These are some of my editorials. I don't really have much there at the moment. Beyond EMDR is when I'm bringing stuff in that is not veteran related, but not specifically EMDR related. So you're going to find other subjects, sleep, tobacco harm reduction stuff in there, so you'll find that there. Anything else? Watch, listen. This is where you'll find the up here is where you'll find um, the podcast. And the podcast is basically a auditory version of the things that I write in the other areas. So you should be able to get that work. Down here is the live desk replays. So it looks like we already put those up, and you can see those here playing from YouTube, and kind of just lets you go and replay these pieces. Latest video replays. Okay. So that's that. And then the brief, if you haven't already signed up for the EMDR News Brief, please do. If you want to go to the brief, you can go and click on Get the Brief. And then once it takes you there, it's a second for us to transfer over as it goes through this process. But here we go. This is the interesting, the most current brief. I'm gonna have to tell them to fix it because they're supposed to also have up on top. They're supposed to leave in the place where you sign up, but they took that out for some reason when they put this new piece up. So this is the issue 4, right? So we're not going to give you the archives for these per se. Um, if there's something that you heard about or something, I do have access to them, and you can ask me for them. But the current issue is going to be up here, just so that people can come and see it, right? Come and sign up, seeing if this is of interest to you. So this is what that looks like. And this goes into what's been on basically this week, or some other interesting pieces. Okay, so this will touch on the podcast as well, and then you can get your brief in your inbox and just sign up there. All right, so please do sign up. Very be very good to have you. All right, let me go ahead and come back to just you and I. So that's all we're going to go over for today. Let's do one more check. Yeah, let's do one more check. What I'm doing is I'm just going to let you know what we're going to be doing tomorrow. If I can bring that up. Dun, dun, dun. Here it is. Make it easy on myself. One moment. All right, here we are. So, so we have today was psychosis in EMDR. Tomorrow is imagery scripting in EMDR. And one of the things about that is when we have people that have a lot of childhood trauma, sometimes just doing EMDR doesn't get to where we want to go, right? Just EMDR as is. So if we do EMDR and include imagery or scripting, sometimes that could have a better effect for that population. So if you're having trouble with that population where they have a lot of childhood stuff, they might not have borderline tendencies, or they might not be borderline clients. But when you think about the history of a borderline client, some of the stuff, neglect, the stuff they had in their past, that's the type of stuff that you might see that might benefit from the imagery scripting and EMDR work. So I'll be bringing that information to you tomorrow. Wednesday should be a continued discussion on EMDR 2.0 mechanism stuff and Flash. We'll bring in Flash. Didn't mention Flash last time we were talking about these things because, I mean, Flash is a good tool, but it doesn't fit within the EMDR context of things. But again, here I'm not just trying to stick with the formal definition of EMDR. I'm trying to expand it a little bit so that we can talk about trauma more broadly. And then we're going to, the Thursday, talk about group EMDR and scalable treatment. And then for Friday, Red Friday, we're going to be talking about military culture. And what I mean by military culture is, and I'm going to give a shout out to one of the TikTok, I think, influencers, Instagram maybe, but rapid fire. Um, you talked about stuff about military culture and just that transition of becoming a civilian and what it's like. If you're outside of the military culture and you're watching some of this, or some of this is happening, you might think like, hey, there's something wrong with these people. But the argument for Friday is it's not something wrong with us, right? It's not something wrong with the military or veterans, right? It's not being or having been in the military and being affected by it and learning those lessons. It's not a mental health illness, right? So we're going to be talking a little bit about that, a little bit how culture kind of plays in military culture and veteran culture plays into how they act and interact with other veterans and maybe, their families and society in general. So I look forward to having these conversations with you. And if you have any questions, thoughts, concerns, any ideas, please reach out to us. And yeah, we'll be seeing you tomorrow. So this has been Dr. Vermillion at EMDR News, and have a great day.